Assalamu alaikum. Today we will be discussing about the medullary disease, and we'll be starting. Medullary disease is in fact an extensive part of the topic. Among the ear diseases, medullary diseases are the most things to be discussed, and this of which there are acute suppurative otitis media, there are chronic suppurative otitis media, there are otitis media with effusion, and there are few other diseases. These are infective conditions and non-infective conditions like otosclerosis, adhesive otitis media, and other diseases we will be coming to consider in course of time. But here today, our main thing is to start with the disease of the middle ear. And we have already discussed about the diseases of the external ear. In the disease of the middle ear, here, discharge from ear, discharge from the ear canal. We have already discussed while we have been discussing about the disease of the external ear that there are discharges, there are pain and associated conditions. But here, especially I mentioned again these things, the source of this discharge can be from the external ear, can be from the middle ear. Here CSF, it comes from the surrounding part of the brain and comes through the middle ear and then to the external ear, and the discharge comes to the external ear. Blood can become from middle ear through the external ear. Mucus, when the discharge from the middle ear, discharge from the external ear contains mucus, it is definitely coming from the middle ear. Pus, in most of the cases, pus comes from the middle ear. Wax is a product of external ear, and lot of debris that in the external ear can also form in the middle ear. So I repeat this part because these discharges can come from external ear, can come from middle ear. From the internal ear, there is no disease that causes discharge. And I again like to mention all the diseases that affect the external ear and middle ear will cause conductive type of deafness, and the disease of the inner ear will cause perceptive or neural, otherwise called sensory neural deafness, and disturbance of the balance, problems related to vertigo. To start with, acute suppurative otitis media, and then we'll go for chronic suppurative otitis media, its complications, and a lot of other things we'll discuss, and other diseases of the middle ear also. Acute suppurative otitis media. The name itself have its definition and description. It's an acute infection. It is a suppurative. Suppurative means pus forming disease. Otitis media is middle ear disease. So the definition is here: acute inflammation of mucoperiosteum, not only mucosa, mucoperiosteum, because the mucosa is tightly adherent to the periosteum. When the mucosa is inflamed, the periosteum is inflamed. Acute inflammation of the mucoperiosteum of the middle ear cleft by pyogenic organisms. We will come to discuss what are the pyogenic organisms, or other words, we can say these are exciting factors of the disease. Under some predisposing conditions, there are some exciting factors which we discuss with bacteria, the pyogenic organisms. But one thing here to be specially noticed, this used to get mistake during examination and during thinking of the disease: acute inflammation of the mucoperiosteum of middle ear cleft. What is middle ear cleft? I have told you during the process. I have discussed about the anatomy of the middle ear. Today, I'll just also show the same thing again, the middle ear cleft. So this is the definition. This is an acute inflammation. This is suppurative organism or pyogenic organisms, and the part affected is middle ear cleft. Cleft, in fact, contains mostly ear and ossicles and muscles and ligaments, but the inflammation is in the lining wall. The lining wall is mucus, and mucosa is so strictly adherent with the periosteum, so the word mucoperiosteum comes. Acute inflammation of the mucoperiosteum of the middle ear cleft by pyogenic organisms. This is the definition. This is the middle ear cavity. I have shown you this picture, how to draw it and how to, I'll give you, if at the end of this, I'll give you a sketch of this, how we will draw these things whenever comes in examination. And here, the middle ear cleft, which is composed of, this is the middle ear cavity, this is the Eustachian tube, this is the editus adentrum, this is the mastoid antrum, this is the editus, this is the mastoid antrum, these are mastoid air cells. All this air containing space is called middle ear cleft. When there is some inflammation in the middle ear cavity, there is some inflammation in the Eustachian tube, some inflammation in the editus adentrum and mastoid air cell system. And there are bony septum in between the air cells, sometimes they get dissolved. So we'll be coming on the acute supportive hepatitis media, and in the last part of the today's discussion, we will give some light on acute mastoiditis. This is the middle ear cleft. And when you call middle ear cavity, it means only this part, only this hexagonal part. So middle ear cleft is middle ear cavity plus Eustachian tube plus editus adentrum, mastoid antrum, and air cell system. Etiology, why acute supportive otitis media occurs? There is a number of factors, what we call predisposing factors. Some of the factors we call exciting factors. The predisposing factors are age. Children are most frequently affected because the infection of the middle ear not goes from the outer ear canal. It goes through the Eustachian tube. And any disease that affects the upper respiratory tract infection have high chance to go to the middle ear. And in children, the Eustachian tube is straight, is wide, and less tortuous and short. There are three characters. It differs with the adults. It is short, it is wide, it is straight. And this, when the human child grows, it becomes tortuous, it becomes narrower, and it becomes longer. In case of children, especially male children, get more affected by this disease because the female childs are less outdoor, less moves to the outdoor. But with the parents, usually with the father and with the mother also, the male child get more interested to go out in the early of their age. So among the sex, it is more frequently observed in male child, but even it also occurs in females also. Nutrition, the poor nutrition, poor nourished, and causes less body immunity, and less body immunity will definitely high chance of infection. Hygienic conditions, those who are not that much neat and clean, there is more chance of infection from the nose, from the throat to the middle ear cavity. Socioeconomic condition, this is indirect effect on the nutrition and hygienic conditions. Poor socioeconomic condition, but we have seen a lot of poor people, lower middle class people and poor people, they maintain a very high level of hygienic conditions. It depends on the training of the family. It depends on the training of the parents and mostly of the mother. The socioeconomic condition, the habit. There are some bad habits and overcrowding and bad habits. Socioeconomic condition also affects the bad overcrowding. There are once upon a time, there was lot of brothers and siblings in a family. There are 10, 11 siblings in a family like that. There are 5, 6 was very common. And even the time is like that. We are 11 brothers and sisters. Me also a member of a family where we have 11 brothers and sisters. This was the scenario of this country once upon a time. And so this socioeconomic condition and hygienic condition bad habits. This relates to the upper respiratory tract infection, allergy, and adenoids. You will come to discuss with the adenoids. Enlargement of adenoids, it is the nasopharyngeal lymphoid tissue. When it gets enlarged, it causes dysfunction of the eustachian tube. So upper respiratory tract infection, allergy, adenoids, these are associated. So these are the points, these are the predisposing factors which causes upper respiratory tract infection, and that leads to the medullary infection. Exciting factors means bacteria responsible for not only ear disease, the upper respiratory tract usually get infected by these 5 microorganisms. I will request you to memorize these things. You can see what are the organisms that causes acute tonsillitis, this is the list. What that causes chronic tonsillitis, this is the list. What that causes sinusitis and rhinitis, this is the list. So what causes the medullary infection, this is the list. So the Streptococcus pneumoniae, or what we call Streptococcus, of which the commonest Streptococcus pneumococcus is the other name is Streptococcus pneumoniae, or pneumococcus is very common. Beta hemolytic Streptococcus that causes infection in the skin, soft tissue, upper respiratory tract, tonsils, and areohair, and associated with a lot of distant and local complications related to tonsillar infection. You'll come to know later in detail. And these two organisms have the highest frequency of infection are Streptococcus and Haemophilus influenza. Haemophilus influenza is also a very common upper respiratory tract infection causing organism that causes acute suppurative otitis media is also part of the infection we call upper respiratory tract infection. And Eustachian tube is also a part of upper respiratory tract, including the medullary. Moraxella catarrhalis. Moraxella catarrhalis is an organism that recently, in last 20 years, we have recognized that there is another organism that causes upper respiratory tract infection, especially Eustachian tube and medullary diseases, and Staphylococcus, rarely, but it also causes. Staphylococcus is an organism that usually causes infection in the hair follicles and other parts, superficial parts of the body. They usually do not enter inside, but at times when the body immunity is poor, they used to go. These 5 organisms, Strepto, pneumoniae, hemolytic streptococci, Haemophilus influenza, Moraxella catarrhalis, and Staphylococcus. You have to memorize by going a number of times through this. These are the organisms. Pathology, rather pathophysiology, rather sequence of development of this disease. Very briefly, I am presenting this is that the disease, sulfings usually stands for ovarian tube, ovarian sulfings. Sulfings means any tube. It's a French word. Acute eustachian salpingitis. The disease starts with that. Then it comes to acute tympanitis. Then A, B, C, and D. There are 4 stages. In stage C, it goes to resolution. In stage D, it may proceed to acute mastoiditis. These 4 stages, the pathology is described. Acute eustachian salpingitis means there is inflammation of the eustachian tube, causing blockage of the eustachian tube. Tubal occlusion, tube blockage due to engorgement and edema of the meatal wall, tubal wall, that causes exudation in the medullary cavity. Why? When the eustachian tube is blocked, air can ventilate through the eustachian tube to the middle ear. When it is blocked, it can't ventilate. There is blockage, air cannot go inside. The oxygen and the other gases are absorbed by the middle ear mucosa. There is a negative pressure. There is an empty space, negative pressure. And because of this, there is exudation of fluid follows from the surrounding wall because it is associated with inflammation. The fluid is exudate. It is protein-rich fluid. And there is other disease we will come to know when there is transudate, a fluid which is protein poor fluid. And serous fluid also, it comes, and initially the fluid is serous, and then it becomes mucopurulent. Orthat there is pus and mucus secretion is there, it continues to accumulate. So in acute Eustachian salpingitis, the disease is that this is the acute supportive otitis media, and that's why we are telling it again and again that the disease is inflammation of the middle ear cleft, because the Eustachian tube, the editus adentrum, the mastoid antrum and air cells are part of the middle ear cleft in addition to middle ear cavity. So the middle ear cavity is going to be affected, but the disease initially starts in the Eustachian tube. So this is called, we call Eustachian salpingitis. There is tubal occlusion due to engorgement and edema. There is absorption of the air, exudation of fluid, and serous efferts and mucopurulent. This part is the Eustachian salpingitis. Acute tympanitis, when the middle ear cavity is filled with fluid and when it becomes mucopurulent, when there is pus comes, the stage is called acute tympanitis, causing bulging of the tympanic membrane may proceed to rupture. Initially, the tympanic membrane bulges out and there is ultimately the tympanic membrane ruptures. Why the tympanic membrane ruptures? Because of the pressure of the inflamed pus and this pus and inflamed material, there is hyperemic decalcification. The tympanic membrane is very thin. When there is hyperemia, there is decalcification, this part ruptures. And in acute tympanitis, there are two stages, pre-purpurative stage and post-purpurative stage. This pre-purpurative and post-purpurative stages are this part of this acute tympanitis. And if treated adequately with proper antibiotic, or the patient's body can cope with this, the bacteria by their immunity they can overcome, it undergoes resolution. And the rate of resolution is more than 99%. You know, all the people, all the children, the British statistics is that all children, 100% children of their families have acute suppurative otitis media once in a life. So we all had acute suppurative otitis media, but in health delivery system of our country is so poor that whenever some earache in the children, all times the parents, the mother goes to the doctor with this child. But in our country, not only with slight pain, usually we do not go to the doctors. Our parents have not gone to the doctors. When there is severe pain that the child cannot sleep for a night, only in that situation. Moreover, in acute suppurative otitis media can be so transient, so short periods attack that whenever the child sleeps, the Eustachian tube blocks, the infection starts, the child cries at night, and the mother goes up and wake up and take the child on her shoulder, and whenever the head is taken up, the Eustachian tube opens and the child again continue to sleep. These also are situations of acute Eustachian salpingitis, part of acute suppurative otitis media, which may continue to follow the other steps, may not follow the other steps, but this is part of the acute suppurative otitis media. In acute tympanitis, I again repeat that there are two parts, pre-purpurative and post-purpurative. Because of the accumulation of pus, which continues to accumulate, continues to increase in amount, causes hyperemic decalcification of the tympanic membrane, causing rupture of the tympanic membrane, or it resolutes. Infection up to that stage, it stops, or it continues to acute mastoiditis. What is that? Whenever there is acute suppurative otitis media, some degree of mastoiditis is there. Some degree of mastoiditis is there, meaning that the mucosa of the mastoid air cell system is always affected, which may have resolution also. So there are 4 stages of the disease. And this acute mastioditis is a part of acute supportive otitis media in early stage of this. But when it continues after the treatment, even does not go under resolution, we continue to discuss this as a different disease, acute mastioditis, and will come after this acute supportive otitis media. There, one thing I have written, osteitis, which causes subperiosteal abscess behind the ear. Why osteitis? Why not osteomyelitis? Because the bones of the skull do not have medullary cavity inside, do not have uh, bone marrows inside. So the infections of the skull bones, most of the cases we call osteitis. This osteitis has another name, caries. When we consider teeth as a bone, does not have any medullary cavity, not affecting the pulp region, affecting the surface outer part of the bone, we call caries teeth. Even at the same time, when the spine of the human being is affected by infection, it is called osteitis and it is called caries spine. And caries means osteitis not involving any medullary cavity. This is subperiosteal abscess. We'll be coming on that. Clinical features. What happens in acute Eustachian salpingitis? Acute tubal obstruction means acute Eustachian salpingitis. There is feeling of fullness in the ear. The ear is full, blocked. There is conductive type of deafness with autophony. Autophony means I can hear my own sound. I think most of us had this experience when we had a cold attack, when the Eustachian tube has been blocked. Even the outer ear canal is also blocked, there can be autophony. So when the outer ear canal is clear, it is acute tubal obstruction, fullness of the ear, and slight deafness with autophony. When you observe the middle ear, want to examine, the tympanic membrane will be retracted. What is the sign of the retraction of the tympanic membrane? The tympanic membrane is placed obliquely, but we can see it is inward, drawn inward. Retracted means it is drawn inward. There are blood vessels in the tympanic membrane. Normally, tympanic membrane is transparent. Here, tympanic membrane is translucent. And the blood vessels, due to inflammation, before perforation, the blood vessels can be seen. Small blood vessels can be seen when we place light over the tympanic membrane. This is the sign when there is acute tubal occlusion. Means acute supportive otitis media have started. The acute tubal occlusion stage, also acute supportive otitis media have started. Acute tympanitis, the middle ear infection. The main part of the middle ear infection. The and discomfort increases. There is earache, there is constitutional disturbance. You will hear many times from many teachers, constitutional disturbance means fever, headache, malaise, nausea, vomiting, weakness. These features, these 4 or 5 features are in a word called constitutional disturbance. When there is acute supportive otitis media, there is, in addition to earache, there is headache, there is fever because there is accumulation of pus, there is associated with nausea, associated with even at times vomiting also. These are constitutional disturbance. All these continues to increase. In post-perforative stages, when the tympanic membrane perforates, how it is perforates? By hyperemic decalcification. when the tympanic membrane perforates, there is discharge. The discharge appears in the ear. After stage, pre-perforative stage of acute tympanitis, there is no discharge in the ear. And we need not to give any medicine in the ear. Only we have to give patients to eat medicine. We will coming to discuss the treatment and in whose stage what to be given. We will come to that. In post-perforative stage, there is discharge in the ear, pain subsides and deafness increases because the tympanic membrane is lost in a part, and this may be a big part, this may be a small part, and when there is a perforation, the deafness increases. But pain subsides. The pain was due to pressure of the pus. There is hemorrhagic fluid, mucus and blood stained fluid in the medullary cavity. So this stage, after the perforation, the patient's deafness increases, the ear become more deaf, more heavy, more the type of conductive deafness, but the pain subsides. Post-perforative stage, there is otorrhea and relief of pain. When we examine in acute supportive otitis media, even in pre-perforative stage, examination of the ear become sometimes difficult. We have to be very keen to examine the patient. Resolution: return to normal in few days to few weeks. What happens? There is fluid in the medullary cavity, which is pus, blood. Now, when the resolution starts, this blood and pus gradually become water. The bacteria and the pus is going to be absorbed, and Eustachian tube is going to open, and so air enters into the medullary cavity, and there is a feeling of obstruction in the air for few days, and at times few weeks. So, whenever a patient of acute supportive otitis media comes to us, we will give treatment. At the same time, we will give some advices. At the same time, we will give some idea in how many days they are going to relieve. Otherwise, they are going to treat, they are going to cure. Otherwise, after taking few medicine for 2, 3, 4 days, they will go to another doctor. He will give some medicine, and he also, if do not tell about the duration, how many days it will take, the patient may go to another doctor. We have seen this, and from this experience, I can tell you that you always, everyone will tell the patient that you have to wait for 2 to 3 weeks. It may take 6 weeks to ear come to the normal if there is no perforation of the tympanic membrane. And if there is perforation of the tympanic membrane, it takes more time to tympanic membrane to heal. If some precautions are taken not to allow water into the ear, not to clean the ear, even after that, they have to routinely use the medicine that is prescribed. Acute mastioditis, the part of this medullary infection, pain in the mastoid region, there is some pain, tenderness, and edema in the posterior wall of the ear canal. Constitutional disturbance increases. In the stage of acute mastioditis, when we will define, I have told you, in all cases of acute supportive otitis media, there are some degree of acute mastioditis. But acute mastioditis, we will label as a disease when after acute supportive otitis media, pain continue to increase, there is tenderness, on examination, there is edema in the posterior superior wall of the ear canal, and constitutional disturbance, headache, nausea, vomiting, weakness, fever, malaise, all this continue to increase. Then only we will define as acute mastioditis. Treatment. Treatment of acute suppurative otitis media. Two things have to mention: pre-perforative stage and post-perforative stage. Before perforation of the tympanic membrane, after perforation of the tympanic membrane. In whichever stage we had the patient, after perforation of the tympanic membrane to give ERA comes whenever you tell acute suppurative otitis media, just some teacher jump to you that directly you tell me what is how you would give a prescription of a patient with acute suppurative otitis media, including advices. And you have to be very careful to mention all these things. Number one, rest does not mean bad rest. Means he have to work less than normal. Even he have works, he have to be very careful. Official workers and other people have to be very careful because it is associated with nausea, it is associated with vomiting. So he may feel dizzy also. So the rest, some have to, because if one has fever, if one has body ache, if it was a malaise, if he has nausea and vomiting, he have to take some rest, not bed rest, not hospitalized. Local heat, avoid cold, and steam inhalation. These are physical measures. Local heat, you know, not hot things, but warm heat when given in the ear, it is comfortable. How heat will work? If you heat the ear, there will be more rise of temperature in the region, causing increase in blood circulation, and increase in blood circulation will wash out the inflammatory substances from this region. It helps. Moreover, always warms are comfortable. All warms are comfortable. Avoid cold, very simple, all you understand. Steam inhalation. In all these diseases that associated with upper respiratory tract infection, steam inhalation is very useful. Here, boiling water from a distance of 1 feet to one hand, 12 to 18, 18 inch away, when the steam comes out, you can add menthol, Vicks, eucalyptus oil, tincture benzoin co, anything you like, or adding nothing. Steam is very useful. It works as a decongestant and it works as a soothing agent. Feels better. Sedation. Sedation here, if someone is very difficult to get sleep with this pain, can be given, but here antihistamines work as a sedative for that. We'll be coming to antihistamine. Analgesics, because it is a very painful condition, acute suppurative otitis media. For example, paracetamol 500 milligram, 3 times in a day. You have to mention it is to be taken after food till pain and fever subsides. Sir, I will give analgesic. If you stop like that, all examiners are get annoyed. What analgesic you will give? Sir, paracetamol. How you will give? How much you will give? If it is children, you have to mention the dose, you have to mention the duration of treatment, you have to mention the route of application, and you have to mention the strength of the any medicine you mention. So whenever you mention an analgesic, I will give paracetamol, you have to tell all these things. Whenever you mention, this is a very opportunity. This is a very good opportunity for the student to pass time during the examination, telling in details of this about the medicine. Antibiotics, systemic antibiotic, amoxicillin 500 milligram 3 times in a day for 7 days or 10 days. You can mention anything. I'll give 7 days, okay, I'll give 10 days. I'll give ciprofloxacin 500 milligram 2 times in a day for 10 days. I'll give levofloxacin 500 milligram daily for 10 days. I'll give ceftriaxone 400 milligram daily for 10 days. Whatever antibiotic you mention, you have to mention for dose and duration and route of application, probably to be taken orally. Nasal decongestants. I think it needs some explanation of nasal decongestant. To open the Eustachian tube, it is very important to treat acute suppurative otitis media. I have written here very shortly. Of this, xylometazoline and oxymetazoline, two drugs are very popular. Xylometazoline is an older drug and oxymetazoline is newer drug. Xylometazoline is given in 0.05% and 1%, and in children 0.05%, in adult 1%. And the child and adult difference of baseline of age is 12 years. Child means here, only for this drug, child means 12 years. We know normally child means 18 years, but here only for when it means that nasal decongestant for children, it means up to 12 years of age. After 12 years, it is adults. So xylometazoline hydrochloride is to be given 0.05% for children and 1% for adult. We have to instill 4 drops, not 1 or 2 drops, because the medicine, the drop have to go to the Eustachian tube in the nasopharynx. So, and the patient have to feel the bitter taste of the medicine. Though sometimes the child used to refuse to take, but they have to convince after even initially starting few drops and then 2 drops, 1 drops, and then 4 drops, or the child accepts it have to give 4 drops, far nostril, 3 times in a day for 10 days. This is a very bad drug. This nasal decongestant, xylometazoline and oxymetazoline. Oxymetazoline is a half strength of that, 0.05% for adult, 0.025% for children, and child means 12 years. It is also to be given in same dose. It is better tolerated. But these two drugs, when given as a nasal decongestant, have development of resistance. So, development of drug resistance. It's not antibiotic resistance, it's development of drug resistance, meaning that increasing dose of drug is required to have the same pharmacological effect. Means if you continue to give, you have to increase the dose of the drug to have the same effect. These are usually prescribed for 7 to 10 days, never to continue for a long time. If you continue to for a long time, there will be rebound effect. Rebound means initially nasal decongestion, and if you continue 2 weeks, 3 weeks, 4 weeks, there is recongestion and more congestion than normal. So this drug should not be used continuously or irregularly for a long time. Even sometimes one phenomena is observed called tachyphylaxis, that is rapid development of this tolerance, rapid development of drug resistance. We call tachyphylaxis. It means that if ephedrine was the older drug which used to develop tachyphylaxis. So now the better drugs are here, but we should not continue for long time. Antihistamines, fexofenadine, 60 milligram for children less than 40 kg of weight, 120 milligram up to 60 kg of weight, 180 milligram more than 60 kg of weight, to be taken daily at night for 1 month. It can be continued for 2 months. Antihistamines. Antihistamines we call systemic decongestant. It reduces the exocrine secretion all over the body, all respiratory tract, gastrointestinal tract, oral cavity, everywhere. So we want to reduce the secretion of the middle ear cavity here by giving antihistamines. You can give any antihistamine, chlorpheniramine maleate, promethazine hydrochloride. You can give any antihistamine you like. And now rupatidine, estivastatin, ivastatin, a lot of antihistamines are now available. Rupatidine 10 milligram once daily at night is very good. Even diphenhydramine is or loratadine also non-sedative antihistamine, but they have got subsedative effect. But whenever antihistamine is non-sedative, its antihistaminic action is no more. All antihistamines have some sedative effect. Minimum a few amount of drug also crosses blood-brain barrier and causes sedation. And this is the standard treatment I have described is for acute suppurative otitis media pre-perforative stage. When there is perforation of the tympanic membrane, we have to give gentamicin ear drop. We have to give ear drop 3 times in a day 3 to 4 drops in the affected ear 3 times in a day for 15 days. How it is to be given? It is to be given in displacement method. I have not written here. I will come with this on. We will be going for chronic supportive otitis media. But in acute supportive otitis media, after perforation of the tympanic membrane, the patient's ear have to be instilled with 3 drops, and then the tragus, you have to push tragus for 3 times so that the medicine goes inside the medullary cavity. So this is we call displacement method. When we will give eardrop? After perforation. Pre-perforation, the nose drop, the nasal drop is the best medicine in addition to this drugs. Local treatment. This is autotrophical antibiotic after perforation. Gentamicin, 0.3%. At times we used to ask, what is the strength of this? What are the medicine? There are some people who say amoxicillin. In fact, amoxicillin is not a preparation for local antibiotic. So you have to definitely know what are the drugs that are levofloxacin have preparation, gentamicin have preparation, chloramphenicol have preparation, to apply locally. So you have to know what are the drugs. Solin is also 3 drops. Ear is full of pus. Initially, may need to be cleaned. And myringotomy is a treatment for acute supportive otitis media before perforation, when tympanic membrane is so tough that it is not getting perforated, pus accumulates in the ear, and the patient cannot sleep at the night because the patient, the child or adult who cannot sleep at the night because of so severely painful condition. In that case, we just myringotomy means we just make a small perforation by a small incision by a myringotome. Myringotome is a small instrument with tip is lancet like, and we just give a tap, and the pus and water pus mucus comes out, and the patient gets rid of pain, and at the same time the patient relieves very rapidly. And cortical mastectomy will be coming when the inflammation is not going. We'll be coming to when in the next part of our today's discussion on acute mastoiditis. So this is the treatment of acute supportive otitis media, and this is the clinical presentation and symptoms, signs, and in which normal tympanic membrane is pearly white, and you have seen tympanic membrane in the beginning, that the tympanic membrane with inflammation. In acute inflammation, the tympanic membrane is pink, and this is the handle of malleus. At times, it becomes fissureless. The tympanic membrane is bulged, and there is flaming. There is light. There is something like some burning. This is the acute supportive acute inflammation of the mucoperiosteum of the medullary cleft by pyogenic organisms. This is the acute supportive otitis media, which has 4 stages, and it is to be treated. Now, acute mastoiditis. Acute mastoiditis is a complication of acute supportive otitis media, or it is the continuation of the 4th stage of acute supportive otitis media. Here, the picture shows that there is bulging of the posterior auricular medullary infection. It follows acute medullary. Acute mastoiditis is inflammation, osteitis of the mastoid bone. I have told you what is osteitis. Osteitis of the mastoid bone after the medullary infection, presenting with pain, fever, and post-auricular swelling or swelling behind the ear. And usually the patient usually show us that this ear is severely painful, and when you see the behind, there is swelling, abnormal swelling. We can compare with the opposite side. The disease is mostly unilateral, almost always unilateral. Clinical features. The patient has history of discharge ear. In acute mastoiditis, the patient has history of discharging ear. He has history of ear discharge, means history of acute supportive otitis media or chronic supportive otitis media. He has pain, swelling behind the ear, and fever. These are the symptoms, and these are the signs also. But one thing is that he has history of discharging ear, swelling behind the ear. Here you can see this is a patient whose there is pus and swelling. The incision is given, and you can see pus and blood are coming out from the ear, postauricular region. This after this incision, when the mastoiditis does not resolve by itself, the mastoiditis progresses, then we call it acute mastoiditis. There is osteitis and inflammation causing pus formation. You can see blood stained pus there. This difference between acute mastoiditis and furunculosis, I also have discussed it when I have been discussing the disease of the external ear canal. Here also I will again comment on this, because this is a very common question that comes as an SAQ as well as if furunculosis and mastoiditis. Almost all the points are there. You can see site. Furunculosis occurs in outer ear canal, that is a staphylococcal infection in the hair follicle of the outer ear canal, causing severe painful condition. And mastoiditis is a disease of the middle ear and mastoid. History. No preceding history of otitis media, meaning that the patient do not have any ear disease at all. But here in mastoiditis, patient usually have middle ear disease. He have discharging ear, he have acute supportive otitis media, he have chronic discharging ear. কান থেকে প্রায় পুজ আসতো, he had pus coming out from the ear canal repeatedly. After a few days it stops, after a few days it comes again, after when water entry or cleaning or upper respiratory infection follows discharge from the ear. This is the history. Deafness. In furunculosis, there is no deafness. Only when the furuncle is so big to occlude the ear canal totally, this is a very rare situation, because before that, in most of the cases, the furuncle ruptures and pus comes out. But even then, it can occur. And deafness is always present in acute mastoiditis, because it follows middle ear disease. When there is middle ear disease, there is deafness, and there is autophony, there is blockage filling of the ear, the patient is. Tympanic membrane. No sign of any disease in the tympanic membrane in furuncle, because furuncle is a disease of the outer part of the ear canal. If we can see the tympanic membrane in furunculosis, because it is so painful a condition, introducing a ear specula, oral speculum, the metallic oral speculum is very difficult. We have to negotiate it very gently so that the patient do not get hurt. The shows the sign of the middle ear disease. Tympanic membrane. Tympanic membrane can show a perforation, can show fissureless, can be dull, and there is some sign of the disease in the tympanic membrane. Pain. When the auricle or TM is moved, and the patient has to move, there will be pain. If the auricle is moved, the patient becomes so light, so painful. If you pull the ear, the patient will be getting up. Light, that the patient become very light and shows sign of middle ear disease. And when the pain in mastoiditis only present when you give gentle pressure over the mastoid, the ear behind the ear. When you give pressure behind the ear. And postauricular groove. There is a postauricular groove between the auricle and the attachment of the scalp. you know there is a posterior groove. When there is a furuncle, it disappears. Means posterior groove, the angle is acute, it become obtuse, and in mastoiditis, it become more acute. It remains. Sometimes it become more acute because of the mastoiditis. Fistula. If the furuncle ruptures, there will be fistula in the outer part of the ear canal because it affected a follicle of the hair, hair follicle in the outer part of the ear canal. So if a fistula is found, it is in the outer part. But if there is any fistula in mastoiditis, definitely sometimes we got it. It is in the bony canal, deep part of the ear canal, a fistula is found. And X-ray. If we go for a simple plain X-ray of the mastoid, in which view we do it? We do it X-ray mastoids, Townes view. In examination of the ear disease, we have told the only one X-ray we go for ears. In X-ray, in furunculosis, it will be normal, but in mastoiditis, the mastoid ear cells will show haziness. There will be the black areas of the ear pockets will be filled up with fluid, so it will show haziness. These are the most important points. Whenever you do any disease, these two diseases, these are the main features. If you can memorize it in comparative study, all the features of this disease will come. Clinical features of acute mastoiditis. The patient have presented with history of ear disease, pain, fever, and swelling behind the ear. When we examine the external ear canal, there will be sagging of the posterior ear canal or there will be fistula. Subperiosteal abscess formation and there is discharging sinus. I have shown you after incision, there is pus is coming out, and pus have the capacity to destroy any structure like bone, like skin, and all the things. So this automatically, if there is incision is not given, there will be discharging sinus behind the ear. Pus will automatically come out. Complications or extensions of acute mastoiditis. There are 4 extensions and or there are 4 complications. This and there are 4 things but we don't mind. But at least you have to know acute mastoiditis. Basalt sepsis or bone basalt sepsis, when the infection goes down from the bone of the mastoid and the pus comes out from the inner surface of the teeth and the pus trickles down through the sternomastoid muscle, causing a swelling in the neck. This is called bone basalt sepsis. The treatment is treatment of the mastoid, acute mastoiditis with drainage of the abscess. Simple incision and open the pus, then that is work. Cetelis abscess. Cetelis abscess means when the inner surface of the mastoid bone is involved and there is attachment of posterior belly of the mastoid. The posterior belly of the mastoid is attached here in the inner surface of the mastoid process and comes through a sling, it hangs in the hyoid bone, and then it comes to the undersurface of the mandible. So this is the anterior belly, and this is the posterior belly. When the pus follows the posterior belly, it comes to the submandibular region. It seems that after a mastoiditis, when the pus is there, there is also pus in the submandibular region. So we have to clear the disease from the mastoid as well as incising and removing pus from here. The patient will be cured. Zygomatic abscess. Through zygomatic process of the temporal bone, at times it is seen this is the zygomatic process that comes in front, horizontally runs in front of the ear. So at times the comes and there is pus and swelling is here. So you have to incise here and pus is to come out and you have to deal the mastoid in the way. We will coming what how we are going to deal a mastoiditis. Acute petrositis or chronic petrositis, deep towards the apex of the petrous temporal bone. At times it is not coming posteriorly, going posteriorly, coming down, coming forward, going up. It goes inside towards the pectus temporal bone, and even it goes towards the pectus temporal bone near the foramen lacerum. Foramen lacerum, through which the carotid enters into the cavernous sinus. So it goes deep up to that. And here is the lateral rectus muscle, the nerve of the sixth nerve goes through that, through near the tip of the pectus temporal bone. And so whenever, after even treating the mastoiditis and the pus have come out, but there is patient still complaining of severe deep-seated pain with paralysis of the sixth cranial nerve. This is the lateral rectus muscle is paralyzed. Then it is called Grady-Nigo syndrome. And the patient at times need to be re-explored, and the pus is to be coming from inside, because pus goes deep into the ear canal. But at times, when the surgeon is very experienced, he used to look all the sides when enter into the mastoid, where there is any track and where it is going in any direction with acute mastoiditis. So there are four extensions: bone basal abscess, citylage abscess, temporal zygomatic abscess, and acute petrositis, which may be when chronic, and when severely painful, it can be Grady-Nigo syndrome. Treatment: conservative treatment like acute supportive otitis media. You can remember easily what we have told: rest, sedation, warm heat, avoid cold, steam inhalation, analgesics like paracetamol 2 to 3 times a day till the pain and fever subsides. Antibiotic, you can give amoxicillin, you can give ciprofloxacin, you can give anything, amoxicillin for 7 to 10 days. You can give antihistamine, rupatidine, fexofenadine, loratadine, anything for a few days or a month. Or you can even give ear drops, you can give nasal decongestant. All these medicines after application, if the condition is not improving, if the pain continues to increase, if the fever does not going to subside, if the patients become more uncomfortable, then we have to go for surgical treatment. Even acute mastoiditis also, in lot of cases, more than 95% situations, the acute mastoiditis can be treated conservatively. But when after this treatment adequately, failure usually occurs because of inadequate treatment. Maybe patient is not taking the drug properly. Maybe the antibiotic which I have been prescribed and the patient is taking is not sensitive to this organisms. He has steam inhalation, he is not taking properly, he is not going for a steam inhalation, he is not regularly taking these drugs. In our country, our poor situation of setting, it is seen in villages, in peripheral part, where there is the rural areas. Whenever there is acute supportive otitis media, acute mastoiditis, the people do not go to a doctor, they go to a medicine shop, takes few antibiotics and few analgesic, and sometimes it get cured. Most of the cases in this situation, even it is not getting cured, and we have to face with complications. And this cortical mastoidectomy, we will be coming to discuss in course of time. There are three types of mastoidectomy. One is called cortical mastoidectomy or simple mastoidectomy or Schwartz mastoidectomy. This is today I'll be telling you cortical mastoidectomy. Then I'll be discussing about modified radical mastoidectomy and radical mastoidectomy. Other two types of mastoidectomy. Here is the cortical mastoidectomy and its indications. Cortical mastoidectomy, when and how we do it, I'll be giving here the principle of the treatment and principle of the surgery. Cortical mastoidectomy, number one, acute mastoiditis not resolving with conservative treatment. I have discussed with you. Number two, acute mastoiditis with complications. Also discussed. In acute mastoiditis, what are the complications? Bone basal abscess, citylage abscess, zygomatic abscess, and Grady-Nigo syndrome, or when it goes to the pectus temporal bone. Four types with complications. Four complications. Mastoid reservoir. Mastoid reservoir is once acute mastoiditis have developed and the bony septum have dissolved and pus have accumulated inside the mastoid bone, and antibiotic could not reach here properly whenever adequate doses of antibiotic for adequate duration of 2 weeks or 3 weeks even given, but unfortunately pus accumulates there, discharging air is not going to stop. We call this situation as mastoid reservoir. In that case, the patient need cortical mastoidectomy. And sometimes when the mastoid, I have told you about the cellularity of the mastoid. 20% mastoids are diploic, some cellular, some cortical, and 80% is cellular mastoid. So when we go for mastoidectomy with a diploic bone, then we have to go for cortical mastoidectomy with myringoplasty. When we repair the tympanic membrane, we have to go for cortical mastoidectomy. And this time, the name of this particular cortical mastoidectomy stands as canal of mastoidectomy, but it is also popularly known as cortical mastoidectomy. It is also called canal of mastoidectomy. There are 4 indications: acute mastoiditis unresolved with conservative treatment, acute mastoiditis with complications, mastoid reservoir phenomena, and with myringoplasty. There are some surgeons who routinely does cortical mastoidectomy with myringoplasty. Myringoplasty means repair of the tympanic membrane. When we will go for chronic supportive otitis media and its treatment, we will see the cortical myringoplasty is a very recognized form of treatment. Principle of cortical mastoidectomy. The basics of cortical mastoidectomy is incision, a curved incision between the hairline and root of the I don't know whether all of you are here. A standard posterior incision is a curved incision between the hairline and root of the auricle, starting at a point vertically above the external ear canal up to the tip of the mastoid. You can see the thing is that it is a curved incision. Incision is carved in between the root of the hair, root of the ear pinna. Root of the pinna is carved. The hairline is carved, and in between the gap, in between, almost in the middle of this, the incision is to be given, which starts from a, this is the ear canal, a point vertically above the external ear canal, carved posteriorly down to the tip of the mastoid. It is a standard incision. Mastoid antrum and ear cells are cleared of diseases, bone. Here are, you have seen pus is coming. If you open it, we can see the bone have been destroyed. Bone is diseased. There is osteitis and there is pus. There is debris. All these things we will remove. But the posterior meatal wall is not lowered. In cortical mastoidectomy, that differs with other 2 types of mastoidectomy is that the posterior meatal bony wall will not be lowered, will not be cut. This is the principle of cortical mastoidectomy. By standard posterior incision, a curved incision between the hairline and the root of the auricle, starting at a point vertically above the external ear canal down to the tip of the mastoid. And the mastoid antrum and ear cells are cleared of the bony disease, debris, and posterior meatal wall is not cleared. These are the things practically done. This is the principle. And we used to want to hear from our doctors whenever they come from examination, even in postgraduate or undergraduate. These basic things could not be mistaken, and that's enough to know about these things. Today, this is the total part of this. I have discussed in detail acute supportive otitis media and its treatment, chronic supportive otitis, acute mastoiditis, its complications, and its principle of treatment. Thank you very much.